Detail.
Well, Jackie
Good morning.
told me that she looks up.
In other words,
Hope everybody's doing all well.
She,
I forgot to start with theirs before way into yours. Yeah.
Okay, thanks, guys.
Good morning, everybody. Welcome to Tuesday. Our first report is gonna be our STEM report by Brenda Williams. Take it up. Thanks.
Awesome. Good morning. We'll get started. Brenda Williams, I'm the nursing care manager of our inpatient mental unit, which is 2B stay. And then I'm also the chest pain coordinator. We'll get right into it. So on this particular EMS run, they were dispatched at 5:58 to a residence for chest pain. By 6:12, they arrived to the scene to find a female patient lying in bed. Patient states at approximately 11 o'clock the night prior, she had chest discomfort. She wrote it off as heartburn and took some Tums. States 30 minutes prior to EMA's arrival, she woke up with a dull sensation toward the center of her chest. She ate 10 more Tums with no relief. Reports being nauseous, vomiting, diarrhea. States no cardiac history, would like to be transported to Union Hospital. By 6:13, primary assessment, she was alert and oriented ×4, no breathing problems, pink, warm and dry with palpable pulse. I mean, they had no problems with her. Vital signs at 6:16, 120/85, 61, heart rate, 14 respirators, 100% on room air. By 6:25, they got a 20 gauge IV saline lock and a right AC. The 12 lead ECG showed no abnormalities. She was sinus rhythm. Got her vital signs again, 118/80, 63, 16, 100% on room air. By 6:30, they gave her 324 milligram aspirin. By 6:38, they departed the scene. They remained stable throughout the whole ride to the Union Hospital. No complaint, not in complaint of pain. 6:59, they arrived at they get the Union 702, 12 lead showed ST elevation. I'm sorry. They did at 702 a 12 lead showing ST elevation, V and V4, abnormal V2, V3, ST depression V6 concerning for early stimming. I'm sorry, did it? Okay, I'm sorry, arrival at Union 6:59. By 7:09, cath lab was activated. 7:26, she arrived in the cath lab. 7:55, balloon catheter advanced to target vessel and inflated. So our door to balloon time was 59 minutes. It was successful percutaneous transluminal coronary angioplasty, or what we call a PTCA, of the proximal left anterior descending or LAD with onyx stent, reducing the stenosis from 100 to 0. And she was sent to the ICU.
Oh my,
Wow.
good job.
Quit touching stuff.
Noticed.
Oh God.
Oh, it's just you. It's gonna go great on video.
Oh, I'm sorry.
I really do.
Is it? I mean, that's bad.
I know you want the slide back.
Oh, there we go.
That's one.
So the following morning at 9:40, a code blue was called. Pulse was ready. She was bradycardic on the monitor. They gave atropine ×2, dopamine at 10 mics per kilogram per minute. Transcutaneous pacing started with good capture. They notified her daughter. Patient was intubated and sent to the cath lab. Left coronary angiogram revealed 100% occlusion of the LAD stent very proximally. The LAD stent they just put in the day before. Successful PTCA with a pronto clot extraction of the LAD stent, placement of temporary pacemaker wire, intra-aortic balloon pump or IABP due to cardiogenic shock. That's what they decided she was in. Patient was sent back to the ICU in stable condition. Next day, patient remained intubated, sedated, but mildly awake. Heart rate was regular and still on the balloon pump, remained on dopamine and heparin drips. On day 5, patient became unresponsive with a heart rate in 200s, displayed VFib on the monitor and no pulse was palpable, had been awake and responding on low dose sedation. Daughter was at the bedside and agreed to respect her mother's wishes, so CPR was not performed. A shock type 1 was given, agonal breathing on the ventilator. She was given IV fluid bolus, ventilator stopped for the daughter. The patient expired, throughout. Patient expired. Patient had severe ischemic cardiomyopathy with an ejection fraction of 10 to 15%. And the reason I shared this one is you can do everything exactly right, get her in here, do the procedure. Obviously, the cardiac cath for the EMS getting her to the hospital, did what it was supposed to do. I was telling Barry when I said this one to him, how long had she been using Tums to self-medicate all this time? Maybe she should have gotten here a lot sooner. We're all bad, women really bad about not paying attention to the pain, and not doing anything about it.
Positive, yeah.
Tums or doing other things, so it just goes to show you can do everything right.
Yeah.
I'm really freaked.
Yeah.
But, and then here we go. Door to Blue with the 90 minutes of hospital arrival. Our percentages are a little bit down from last year. We're at 82%. We were 57% for July, but we are working on that. We're working on initiatives throughout PR. Make sure we're doing our troponins. Granted, it was nice that we went to just one troponin now instead of two. And we're working on EKGs, and I know they've been working on getting EKG machines fixed in PR. So working up. So thank you.
Thank you, Brenda. Any question for Brenda? Don't never hit a button again or anything.
Yeah, don't touch that. I'd never get that.
Our next presentation is going to be our stroke report from Beth Harrison.
Yeah.
You may ask a question.
Yeah, exactly.
Don't get antsy and hit it again.
Yeah.
Good morning, everyone.
This is the case of an 81-year-old female. Her prior medical history included chronic kidney disease, heart disease, hypertension, and atrial failure. She'd been on Eliquis, but had stopped it taking it 2 days before due to bleeding from her ear. She said she woke up and had a little patch of blood on her ear, went to her family practice physician. He looked at the ear and saw nothing, but took her off her Eliquis.
Wow.
She was with her family, 81, but she was very active. She got up, she had the roof of her house, came in, developed sudden weakness on the right side facial droop and right-sided weakness. And she went totally aphasic, but she was alert and oriented. She could follow commands. EMS was notified. By the time they got there, she was lying on the living room floor. Okay. Here's the run information. The call was received in 1928, dispatched 1929, en route at 1930, on scene 1932. They were at the patient 1933, departed the scene at 1939, and were at the Union ER at 1950. So really good timeline there. You know, we're talking about 20 minutes from dispatch to she was here. I think he took all the advances out. When she arrived at the ambulance bay here at Union Hospital, she had really progressed in her stroke. Time she got here, her NIH was 21, which shows some severe deficits. She was totally flaccid on the right. She was no longer falling, and she had a left gaze deviation. So when they have a left gaze deviation, right side went out. Totally, her stroke was really evolving. And if your right side is out, you're gonna have a left gaze deviation because you're always looking towards a stroke. So if you have paralysis on one side, your gaze will be deviated to the opposite side of the stroke, usually. There are some kind of strokes that won't happen. They'll be deviated the same way, but for the most part, they deviate opposite of your deficits. She went directly to CT scan. She was in CT at 1950, was completed at 8 o'clock. It was negative for bleed. There was a teleneural consult at 2010. Indicator connected place was given at 2012 for a door to needle time of 22 minutes. So if you think her family called EMS at 1928 and we're giving the TNK at 2012, that is some phenomenal work. Did I go too far? Yeah. After this, they did the TNK, they went ahead and did a CTA of the net at 2151. It was positive acute occlusion of the left M1 segment of the left MCA. And she had significantly diminished flow. So if you think if your M1 is going out of your MCA, put your hand here. That's about how much territory that will go out with a big MCA stroke. That's why she had such a rapid progression of her symptoms. You know, in the field, she was following commands, was alert and oriented. You saw the timeline, time she got here, NIH was 20 and was totally unable to follow commands. She was transferred via air to Indianapolis for mechanical thrombectomy. It was performed and they got a TP3. So for a TP score, that measures how well they get reperfusion through that vessel. 3 is the highest it can be. So they were totally able to recumulate the M1 segment and restore flow to her brain.
Wait.
There it goes.
It's a good surprise.
She did very well. Post procedure, she was alert and oriented, and she was able to follow all commands. She did have very bad expressive aphasia. She did lose her speech, and just some right-sided weakness. But she did acute rehab times 2 weeks in Indianapolis, and then was able to go home with family assist. So from an NIH of 21, even to have any quality of life is pretty amazing. She is still doing outpatient therapy for speech, and it seems to be progressing very well. By the kind of lost her in the notes from St. Vincent's because we don't get their notes, but I kind of picked her back up with her. She's getting therapy through here. So I kind of see how she's progressing and she's doing very well. Case highlights, EMS was called immediately by family. You guys got her there, you called the stroke alert. They were able to clear the CT, we got her there, did that TNK in 22 minutes. Cincinnati and band score were completed. And she had a door in, door out from our ER to Indianapolis in 2 hours and 7 minutes. That is pretty spectacular. Work in the ER and work with EMS to get that accomplished. So she did very well. So it was a very good run, very good documentation on the case. It's one of those cases like Brenda said, we did everything right. She still has symptoms, but the quick response really did save a lot of this lady's brain. So good job.
Thank you, Beth. Get it. Appreciate the button. Next up would be Will. I don't see Will. Will, are you on by any chance? Okay, I'll read it. This is Union Hospital, Clinton. So case number 1, a 59-year-old male, history of cardiac disease, GERD, hyperlipidemia, hypertension, and smoker. Presentation dispatch called med-based with alert that a male patient was driving to them with chest pain. Was going to drive to the hospital, but the pain got worse. Patient's also claiming diaphoretic, took ASA prior to leaving his house and is taking nitro en route. Run history. The EMS was notified at 2120, arrived on scene at 2120, departed scene at 2130, arrived to New Terre Haute at 2152. Wow. Okay. So 59-year-old man was sitting in the passenger seat with his hand in center of his chest. ANO times 4 pale, clammy, diaphoretic, chest pain, radiating to his left arm. Pain was constant. Facial grimace noted. Patient was hooking up car trailer to drive his brother-in-law's house. Brother-in-law stated the patient arrived at 2050 in his house with chest pain. Self-administered 81 milligram ASA, orally 0.4 milligram sublingual nitro. As leaving the brother-in-law's house, patient has history of 1 stent. Brother stated that to pick up the patient to put in the vehicle, patient stated, "I can't breathe." Patient speaking in 4 to 5 word sentences. Placed on cardiac monitor, vital 12 lead, EKG obtained. There's the vital signs on the respiratory effort was normal, clear and equal with breath sounds, 99% O2 on room air. Kept saying, "I can't breathe." Patient was placed on 2 liters. Still complained of shortness of breath. 12 leads showed a sinus rhythm with ST elevations in lead 1, AVL, V2 with reciprocal depression in inferior leads. Second 12 lead was obtained, showing the same as the first. Transport to Union Hospital, Terre Haute. 20 gauge IV was established, left AC. Patient was on administered 243 milligrams of aspirin orally due to self-administering 81. 10 minutes prior to arrival at the EMS station. A liter bag of fluid was hung without wide open. Total of 700 cc's or mL's fluid was given by the time reached ER. A second 18 gauge peripheral IV was established in right AC saline line. Third 12 lead was obtained, still showing ST elevations in one AVL, V2, V3 reciprocal depression and inferior leads. Patient further complaint of some nausea, administered Zofran, and 100 micrograms of fentanyl with slight improvement in pain. E-bridge notification of STEMI was alert. STEMI alert was attempted, not delivered due to lack of cell service. Patient was answering all questions appropriately. Skin condition showed improvement, still clammy, but ink and warm. North 12 lead obtained, still showing ST elevation. IHER was given to the STEMI group. Wow. When they got here, the case was discussed with cardio prior to arrival for EMS report, cath lab activated, 2200 EKG for STEMI, anterior septal with depression and inferior leads. Lab work, chest x-ray completed while awaiting cath lab team. 2226, door in, door out to the cath lab. Cath shows 100% occlusion LAD, angioplasty was 1 stent, 0% residual, discharged home 2 days later. And put a good picture in good STEMI case. Will's been doing these feedback that I've been sending everybody, all the things, and they're really, I send them out, make sure the crews get this feedback, and I know you guys have been doing that, but this is how it comes apart. This is kind of cool. Good picture. Highlights, serial EKGs done to monitor the evolution, significant depression in those inferior leads, and demographic we're trying to reach with our community education for EVAC. Case 2, an 82-year-old female, history of TIAs, GERD, dyslipidemia, diabetes, hypothyroid, nothing good. Patient and her husband were watching TV at 8 p.m. when she became very weak, felt like something was wrong. Notified EMS at 2113, arrived on scene at 2119, departed scene at 2130, arrived at 2134. On arrival, found an 82-year-old female patient sitting on the couch when in her living room. Husband stated that they were watching TV and the patient started to experience blurred vision. Immediately called 911. The patient has obvious right side facial droop upon exam. Primary survey, airway, patent, self-maintained breathing, normal and non-labor circulation, strong radial pulse is present. EKG was normal rhythm without ectomy. AccuCheck is 151 milligrams per deciliter, 92 to 94% on room air. Patient had a positive Cincinnati stroke scale with facial droop, right arm drift, and dysarthria. Immediately contacted Union Clinton ER via cell phone to call for stroke alert, treatment, ALS assessment, oxygen, saline lock, forearm, Cincinnati stroke scale, band stroke scale assessment, and reassured. Transport immediate to transport to UHC. ER with lights and sirens began, and route continued to monitor the patient, taken to the CT scanner. So your treatment at Clinton, 2138, arrival to ED, stroke 1 call, NIH of 23. 39, they're going to CT, 48 returns from CT, telling room begins. 2218, TMK given door to needle was 40 minutes. Swallow screen completed. I'm not sure what that other thing is, to be honest with you. NIH of 2 now. CTA was negative for large vessel occlusion, awaiting bed at Union Terre Haute. At 0630, patient noted to worsen speech, ataxia, repeated CT head, new acute bleed in the frontal lobe, transferred to St. Vincent's. That kind of went a different direction. So we went from a 23 to a 2 back to a 5, heading in the wrong direction, I'm thinking. So. And that shows a bleed there. The delay in the TK due to the amount of family decision time and education. The husband was reluctant for his wife to receive thrombolytics. All vitals and neural checks were completed. good catch on declining speech and ataxia and above assessments. The bleed was caught, neuro was consulted again, and that led to the change in transfer. The early notification by EMS allowed our team to be ready upon arrival. Very good. Tina, you are up.
Right.
All right, so the next presentation is gonna be by Tina for trauma. Hit this button, but you might have to wait. Okay. Don't hit it more than once. Let's see what it does first. This is just sort of delay today.
You just wanted.
Yeah, I have no idea why it's doing this.
Good morning. I have two case studies. This first was 48-year-old male, the MBA. 911 call came in at 1930. They were dispatched 1939 en route 1940 on scene 1948. Departed 1956 and was at the ER at 2000. Called dispatch was 9 minutes. Dispatched en route 1, en route to arrival 2. On the scene to departure 8 minutes and departure to arrival at ER was 4 minutes. So total call times 24 minutes. EMS was dispatched for an MBA with injury approximately 30 miles an hour. Engine and police department was on the scene. On arrival, a patient was standing beside the vehicle, and there was fire department with him. He was a passenger in a vehicle that was involved in a collision where they sideswiped another car. Front and side airbags were deployed. He was wearing a seatbelt. Fire department said that he was agitated, had difficulty breathing, wheezing on the right, and he had swelling of his face, torso. So they assisted him, EMS assisted him to the stretcher, took him to the ambulance. He was alert and oriented ×4, speaking in full sentences, and all of a sudden the swelling in his face got worse. Vitals 168/98, pulse 110, respirations were 37, and GCS 15. So they placed him on non-rebreather IV, put him on the monitor and did his vitals. And then they gave him IM, epi, IV sodium medrol, and Benadryl. Took him to Union ER. This is just a copy or again of our criteria. He did meet level 1 because of difficulty breathing. And his respiratory status and rate. Yeah. So the pre-arrival note at 8 o'clock says MBA driver, positive airbags, anaphylaxis with difficulty breathing, facial swelling. Pressure was 160/110, pulse 106. He was on 30% non-rebreather. I don't get that, but that's what it said. Level 1 trauma was activated, paged out 1958. He got to the ER at 2005. That's what this our ER note said. Trauma surgeon arrived at 2019. MBA restrained passenger, driver sideswiped a parked vehicle at low speed, positive airbags, sudden onset of swelling in his face. He was in severe distress. He was cyanotic. Pulse was 116, rest 18, 99%. Repeat it again on non-rebreather. He had bilateral swelling under both eyes, unable to open his eyes, swelling in his scrotum. Diffuse subacute emphysema, superficial lacerations on his back. He had crepitus all over his entire body. Severe pain in the right chest, diminished breath sounds, all lobes. They put him in a C color, did a fast, it was negative. And then they repeated the subacute epi. At 2020, they gave him Versed and fentanyl. Right chest tube was placed by the ER physician. So the chest x-ray showed moderate right pneumothorax, that was pre-chest tube. Subcutaneous emphysema involving neck and face, extending into the neck soft tissues. Cervical spine showed moderate to severe subcutaneous emphysema extending to the neck, soft tissues. Upper mediastinum with pneumomediastinum. There's also bilateral apical pneumothoraces. And then the CT of the abdomen pelvis showed displaced fractures posterior of the ribs, 9th and 10th on the right. Small moderate pneumomediastinum, probably related to the extension of the right pneumothorax, extensive soft tissue emphysema. Throughout the chest, abdomen, pelvis, white count was 18. They did regular labs. They did not do a drug and alcohol screen. So that's before and after of the chest x-ray. So the diagnosis was MBA, pneumothorax on the right, pneumomediastinum. He was admitted to trauma, chest tube dissection. They ordered SCDs, lightheaded ringers, IV pain meds, labs, and chest x-ray. On day 2, white count was down to 13, still on 3 liters of oxygen. And since spirometry, PTOT was ordered, wound care for his back. Chest x-ray still showed the chest tube in stable position. They continued the chest tube at that time and encouraged him to be out of bed, which he was. Day 3 and changed right chest tube terminating in the apex. No appreciable pneumothorax. White count was down to 11.9. He was out of the chair using his incentive spirometry. Ordered, still getting pain control, PTOT. They recommended discharge to home when he was ready. He was up moving fairly well. Sub-Q emphysema in the chest, but the face was improved. Weaned him off his oxygen and were able, you see his chest tube. Day 4, they did another chest x-ray, just showed a 1.5 centimeter apical pneumothorax, emphysema, subcutaneous emphysema was getting better. One more chest x-ray on day 5 showed continued decrease in the right pneumothorax, and he was able to discharge home with trauma follow-up. So it was kind of interesting. Any thoughts?
Never heard of subcutaneous emphysema going to the scrotum.
I have, but it was like really, really severe fractures, way worse than what.
Especially
that I
bringing
read,
it
I've not ever seen
moderate,
it.
you know, moderate.
Yeah,
chemo.
yeah. So
I
that
would
was
just
kind
go
of
sit on
weird.
that for 9 minutes. It was 9 minutes from the
Yeah,
call to
I
dispatch.
was kind of curious
Actually,
about
wrote it
that.
down.
My guess is they probably put it out as a PD accident.
Oh, okay.
The PD got there,
Yeah, that seemed like a long time, but I'm not real familiar.
and that's literally just guessing.
I'd say that the impact was a little bit stronger than what they said as well.
There's 2 reasons I brought this case up. I mean, one, I just thought it was kind of really strange that they gave, you know, the epi and I mean, that was kind of out of the box thinking, why not? But that wouldn't have been my first thought, but I'm not EMS. The only thing I saw that he was allergic to was penicillin, and I looked everywhere through that chart to see if anybody made mention that he had taken something, ate something. I couldn't find anything, so I think it was just fortunate they were so close to the hospital and got him there in time. And the other thing was the impact, you know. It was 3 miles an hour. He was out of the car, and a lot of people looked at that like, yeah, he's okay. We don't know if he's okay until you know for sure he's okay, and that's why you bring him to us and we do the workup and, you know, the assessment to determine, because they can go from being not so bad to being really bad moments, so. I just thought it was kind of weird. I don't know where the epi came from. I couldn't find it. Didn't know if anybody had any input on that or not.
I mean, I guess, you know, presented with the patient with
You stand
all
up
the
beside the car.
edema in their
Yeah.
face and all of that.
But I don't think it was a demon.
Well, I mean, obviously not.
Yeah.
I think if they had palpated, they probably would have felt the
Yeah,
crackles.
I'm
Yeah.
curious about it, so.
Well, I mean, benefit of the doubt here, the trauma surgeon also gave sub-Q epi on arrival as well. So let's not forget that.
Everybody are doctors, those trauma surgeons, and they actually did start a drip for about.
Seemed pretty bad.
There we go. They went to school.
So we get a lot of cases where they're like, well, they were ambulatory. It's like, well, yes. I've seen a Tim walk in the front door. I've seen a C2 walk in the front door. You, like she said, you just don't know. Plus adrenaline, maybe there was a little substance. I mean, you don't know what was going on. And so, you know, in the immediate, right after the crash, it's really easy to get up and walk around.
All right, so the second case,
Maybe.
yeah, maybe. There we go. This was a 22-year-old male, it was an MBA, 911 call at 14:35. They were dispatched at 14:35 en route at 14:35. On scene at 14:42, departed scene at 15:02, and Union ER at 15:32. Called dispatch 0, dispatched en route 0, en route to arrival was 7. Scene to departure was 20 minutes. Departure to ER was 11, so total call was 2 minutes. So the EMS was dispatched for MVA with entrapment in the driver's seat. It was a pickup, approximately 2-foot intrusion to the driver's door. He was not wearing a seatbelt. There were no airbags deployed. On arrival, patient was screaming and combative, obvious head injury and fractured left arm. He was remaining extremely combative, not forming words, just screaming, fighting. So they gave him 400 ketamine IM, put him in a C color, put him on 15 meters on reader. He became unresponsive after a few minutes and was rapidly removed from the car, placed on board and taken to the ambulance. Blood pressure was 142/100, pulse 120. For 14B, I'm guessing that means ventilated, not sure. 96%. ETCO2 was 40, ECS was 3, blood sugar was 300. He had a copious amount of blood in his mouth. They sectioned out, had some teeth missing. He was intubated with 8.5 ET tube, and breath sounds were present bilateral afterwards. Monitor was sinus TAC. They started 2 IVs. Chest had several abrasions. His left arm was possible open fracture with opening the skin near the tricep area. No palpable pulse unless firm traction was allowed. And I can't see what's behind that. So they did give antibiotics, heart rate. Trauma alert was given and they transferred him to Union Hospital. Pre-arrival note 15:30 is MVA, struck tree, left upper arm injury with decreased pulses. Level 1 was paged at 15:34. He arrived at 15:36. Trauma surgeon was arrived at 15:41. Intubated on arrival, decreased breath sounds on the left. Pulse 150, rest 21. Blood pressure was down to 69/27. 96% on the mat, and GCS 3. Decreased 30 radial pulse, deformity to left mid humerus, puncture wound posterior right or upper arm, and laceration of the left thumb. VAS was positive with free fluid in the right and left lower quadrant or upper quadrants. Sorry. MTP is started. They did left femoral line for fluids. Left chest tube was placed by the trauma surgeon and had a large amount of blood back. Did the usual labs. They did do alcohol and drug screen on him. Type cross, chest X-ray pelvis. They put on a pelvic binder, anchored Foley, put his left arm in a splint, and he had positive pulse afterwards. Weight scale was 22.7, hemoglobin was 12.9. Lipase was 192, CPA was 1650, lactate was 3.9, and TREB was 204. Chest X-ray showed a placement of the left chest tube. Looked like he had pulmonary contusions on the left and a left pleural effusion, left chest emphysema, left diaphragm is elevated, multiple left side rib fractures, lower lobe capacities, probably pulmonary contusions, had fractures of the superior pubic ramus and left tabulum. Diagnosis unrestricted hemorrhagic shock, multiple rib fractures, pneumothorax, pelvic fracture, and acute kidney injury. Kind of see the fracture there. And the chest x-ray.
Yes, this is intestine, it's chest.
Yeah, so I believe that's intestines up in there. I got a point here like he said. Blood pressure remained low in the 70s, even with the MTP and fluids. They were unable to air transport him because of the weather. So he wasn't nearly stable enough to go by ground, so trauma spoke with IU and they were gonna take him to surgery to get him ready for transport. So he went to ER or OR for emergent surgery and stabilization and exploratory lap. It ended up having a splenectomy, repair a colon injury, ended up packing his abdomen with abdominal packs and used the back cover to close it. He had 5 centimeters serosal injury of the cecum, diffuse hemoperitoneum, grade 4 splenic laceration, massive left diaphragmatic injury with stomach and bowel herniating to the left chest, and a pelvic hematoma. So he was transported by Lifeline now from OR to Methodist at 1821. So he did live. I haven't checked on him for a little bit, but. And all I have, this was just kind of a yay, good job recognizing the open fracture, and he had some massive injuries. That's all I got.
So they never did find a head injury then?
Not that I remember, but like I said, it's been a little while, I just did the cursory review.
Do you remember, was this top screen? Cause he was going nuts on scene.
He was, but I don't,
I
I don't think it was
pain.
positive.
Like, it's gonna be-
Yeah, I don't think it was positive.
I don't think it was.
Yeah, I don't think it was.
Hey, before Jared comes up and does his presentation, I'll put this up on the screen again for everybody. We're going to do paving and striping of the east main parking lot, which will include the ambulance bay. So as you can see on the screen, the orange, they're actually doing today, Tuesday the 10th. Then they're going to do the pinks together, then they're gonna do the blues together. The green will be done, blue and green will actually be done together too. So the thought process is orange today, next week, some point in time will be the ambulance bay. When we do the ambulance bay, there'll be no parking to the right of the ambulance bay. All the ambulances will go under the canopy, back in like they normally, and take the patients through the sliding glass doors like normal. We've done this but we did this 4 or 5 years ago. It happens all the time. And so this exact same thing. And then you'll go in that way and you'll go out that way. And then the next time you'll be able to use the bay like normal, and then they'll block this off when they do this, but they're gonna block it off right here so patient can drop patients off here and they can walk into the ER normally also. So just so everybody knows that that's going on and starting today out in the parking lot east, out here further out this way. Matter of fact, it's just right up in here, they're doing it, so. I will let everybody in EMS know the exact date that they're gonna do the ambulance bay, so everybody knows the directions. But next for our presentation is Jared's gonna do some EMS documentation. I'd asked him to do this in a very short amount of time, so I appreciate you doing that for me. So, easy with the button.
Yes. So definitely not my best work. I usually do this documentation training for Terre Haute Fire, during our, paramedic refresher. So I had to change it quite a bit because it's very specific to them. So, some of it's mainly just general information. Nobody enjoys documentation training, but I really do hope you get a little bit out of it. You said I hit the space bar, right? Okay. So some of the resources I use, like I don't cite any of the things in here. I'm just gonna be honest with you. I use a lot of the information in here based on previous trainings that I've attended. So I'm a certified ambulance documentation specialist, and that's through the National Academy of Ambulance Compliance, which is just as boring as it sounds. But we learn a lot about like some of the proper billing practices, and then like things to help you avoid certain litigation. And as most of you know in EMS, our billing standards, our documentation standards are all kind of dictated by Centers for Medicaid and Medicare. So it doesn't matter if they're private pay or a private insurer, everything's kind of set in stone by CMS. So a lot of the information we get is from CMS as well. So our objectives: improve EMS clinical documentation, EMS agency compliance. EMS agencies have to report a specific amount of things as well. So making sure that you're documenting appropriately will make sure that your agency is doing what they're supposed to do. Improve your CMS reimbursement and proper billing practice. I know on the streets, for the most part, none of us are overly concerned about the billing side of things, but it is the nature of business and what allows us to do what we do. We have to make sure that we're doing things to do proper billing. And what I call litigation-proof documentation. Obviously, it doesn't keep you out of the courtroom, but I think if you do proper documentation, a lot of people will settle out of court before you ever have to go up on the stand. So why is this important? Now, again, like I said, I use this for Terre Haute Fire, but I think it's valid for everybody. Our EMS documentation is what allows us to do what we do. It helps pay for equipment. It helps pay for apparatus. It pays our salaries, pays our benefits, does all of those things. So it's important that we do that. But on the other side of that is we also look at the effect that it has on patients. So if you improperly document, that could lead a patient getting a bill rather than patient's insurance is getting a bill. So this is just a bunch of mumbo jumbo. I don't expect you to read all of that, but it's important to know that the number one cause of bankruptcy in the United States is and probably always will be medical debt. And so I think us doing proper documentation, even on the hospital side, is vitally important to kind of avoid us causing some undue stress on the patient. So another reason it's important is law. So we have case law, criminal law, constitutional law, but we frequently come in contact with litigation, especially now. We live in a very litigated society. So making sure that we're documenting appropriately to keep ourselves protected when that inevitably goes to court 5-7 years from now. I wish I could remember exactly what these court cases are, but I know this Tribune Star, you can't see it down here, but it says paramedics sue for their licenses back because a patient who they determined was dead actually started breathing again in the morgue. And so that was actually pretty local. It's in Indiana somewhere. And interestingly enough, they lost their certification through the state because in their documentation, they had no like cardiac monitor strips attached. It was very poor documentation on not resuscitating, and come to find out she was alive. She died 3 or 4 days later. But because of that poor documentation, they lost some certifications. Like I said, I wish I could remember some of these, but a lot of this, like the jury verdict in gross negligence it had a lot to do with a patient being strapped to the cot because they were combative. It was very poor documentation on their part, and EMS was found negligent because of improperly documenting how that they were secured to the cot. So a lot of this, they may have done everything right, but because you didn't document appropriately, you still lost. And obviously we have ethical obligations to this as well, doing what's right and wrong. Or not doing what's wrong, but knowing what's right and wrong. But knowing documentation is patient care. So EPCR becomes a part of the patient's medical record. So just because we're doing it for Terre Haute Fire or TransCare or Riley or whoever, that form will follow them for the rest of their career. So all of the information that they're getting is all from our EPCR. So they use that information in the hospital way more than we even realize. Sometimes nurses or physicians refer back to that to see what was provided, what the scene looked like, how long they were on scene. Obviously strokes, STEMIs, traumas, all those things, they use our documentation. So we have to make sure we're doing it accurately. And then you need to know that the patient's going to be medically and financially dependent on your documentation. So making sure that you're properly documenting so that insurance is picking up the bill. Documentation has to be complete, accurate, and timely, is what it says there. The state of Indiana requires all transport PCRs to be completed within 24 hours of the run. Most agencies require that to be done prior to leaving for your shift in the morning. That's usually pretty good practice. By the way, I have 3 run reports open, Chief. Rough night. But the state requires within 24 hours, and not only that, it's most fresh in your mind is probably the best time to do that. Alright, so talk about the different sections of a PCR. Obviously, most of this is gonna be heavy on EPCRs, because that's what most people use. I recognize non-transport agencies probably don't utilize those, that's fine. The concept is still the same. So, first usually comes up with like incident information, so this is the part where it gets kind of boring, because I'm just trying to put stuff in there. So, they're gonna give you dispatch location, so things like addresses, intersections. You have to check the validity of anything that you import. A lot of us use dispatch. We import that information into our EPCR. Dispatch is great at a lot of things, and sometimes they only get so much information. So they may give you like an intersection of First and Poplar, for example, and when you look in there, it may be a totally different city. So making sure that whatever you import is actually valid and true. Your crew information, putting everybody that's on the ambulance. I put in here students. This is not a popular thing that people realize, but they should. If you have a EMT student or a paramedic student or a rider or whoever on your ambulance, you have to put them in your report as like a non-crew, and you need to put their name. A lot of people put EMT student or paramedic student, which is fine, but in 5 years, when you get a subpoena, they're gonna wanna know who EMT student or paramedic student is. So you need to put their first and last name. Some agencies even require them to sign the PCR. I have not seen where that's actually a requirement, but first and last name is really important. Disposition, how were they transported? Medicaid, Medicare needs to know this. So were they transported with licensed sirens, without licensed sirens, by ambulance, by rotorcraft, by whatever means? They need to know that because it changes the billing code in a lot of agencies. ALS level 1 transport is billed differently than ALS level 1 emergency. So if they're transported licensed sirens to an emergency department, the billing is different. Why were they transported? So this is especially important when it comes to inter-facility transports. So like Transcare, Star Ambulance, whoever, you need to know why they're being taken from hospital A to hospital B. In order for that to be covered by Medicaid, Medicare, there has to be a service that is provided at another hospital that's not provided at the hospital you're picking them up at. So Union Hospital Clinton to Union Terre Haute for cath lab services not available at Clinton would be perfectly acceptable, but you have to document those things. Incident times, again, check validity of import. Dispatch has a lot of calls going in at a lot of different times, so they may have marked you in route and on scene at the exact same time. So make sure that you're looking back through those before you submit your report. Your at patient time, make sure you're giving yourself time to get to the patient. So Diana Luther can tell you this better than anybody, but she had a deposition over a call, and she was kind of questioned by the attorney for the better part of 10 minutes about why it took her 1 minute to get from the ambulance to the patient. So if you're going to like the federal penitentiary, for example, you're talking 5 or 6 minutes before you get to the patient. If you're at a nursing home, you're talking 2, 3, 4 minutes before you get to the patient. So make sure you're giving yourself ample opportunity to actually get to the patient for your assessment. And make sure you document delays. So if you had a prolonged extrication in the field, making sure you're documenting why. If it was a hoarder house, making sure you're documenting why it took so long to get them out. I love to document delays in arrival. So if I'm railroaded on the way to an incident, I always document that I was railroaded. Because if 2 years from now, the firehouse is 2 blocks away and it took them 15 minutes to get here, I want to make sure in my report I put that I was railroaded at this intersection for approximately this amount of time. And then mileage, again, check validity of your import. ESO has a like import function where it uses Google Maps, and anybody who's ever used Google Maps to get anywhere knows that that's not always the most accurate. So making sure that the mileage is correct. The favorite one here is coming from like the POB or the MOB to Union. Sometimes the addresses don't import correctly, and so it'll say it's like 2.7 miles. Patients get billed for mileage. So it is not 2.7 miles to get from the POB to Union ER, maybe 27 feet but not 2.7 times. Your patient information, including demographics, making sure you're verifying the address. A lot of us utilize our hospital face sheets for addresses. If the patient hasn't been to the hospital in 5 or 6 years, it's likely that address is not accurate. So again, that's part of billing, making sure you're getting an accurate address. We also have our patrons, I call them, not frequent flyers, patrons, where we know that the face sheet's gonna be the same as the one that we got for yesterday. Weight estimation. So this is a huge one that I talk about with my students all the time. We give weight-based medications in the ambulance a lot for drips and things like that. If you're estimating weight, put your estimation in kilograms in your report. Because obviously we use sheet math in the back of the ambulance. So our 200-pound patient is 100 kilos. We do that all the time. And so we give medication based on 100 kilos. But if we put in our report that they're 200 pounds, we gave an inappropriate dose of medication. So make sure you put your estimation in kilograms. Allergies, medications, medical history. This section isn't just for show. This is my favorite part of going on patients that I've been on several times before, or that I know we go on several times because it shows up in our system. And I pull it up and it says no medical history, no medications, no allergies. And then they bring out their bucket of medication and put it on my cot. So that information is actually really important for me in 2 weeks if I go on this person who's unresponsive. You know, I'll know that they're on blood thinners and I think that they're having a stroke. That information is important for me to know. And make sure it's consistent with your narrative. That's especially important with like medical history. So if you put in your narrative that patient's given a breathing treatment due to a history of COPD, and then you put in your flow chart that the patient has no medical history, that's inconsistent, and lawyers love that. Then we go on to vital signs. Again, check validity of import. We have this issue a lot with like cardiac arrest. Monitors, AED pads typically pick up compressions as pulse. And so if you have a cardiac arrest patient who never achieves ROSC, but you have documented pulses of 120, 230, 110, 74, that's inconsistent with the information you put in your report. Make sure it jives. Glasgow Coma Scale, ECG interpretation, etc. So you document later in your report that the patient can't sign your form because they're confused, but you document a GCS of 15. That's not consistent. And so Medicaid, Medicare will deny the claim. They do it every time. I can tell you specifically with the city of Terre Haute in 2019, we lost out on like $26,000 just in signatures. So something to consider. ECG interpretation is big too. You document in your report, you know, this is your 10th run today. So you put the patient was in a sinus rhythm, but the strip's clearly atrial fibrillation. Making sure that you're keeping up with that. And then your frequency of reassessment. We all have heard the adage of stable patients get reassessed every 15 minutes, unstable every 5. If you have a hemorrhagic shock patient with a pressure of 50 over nothing and you reassess them every 15 minutes, that doesn't look very good on you on a witness stand. Flow chart. So this was touched on a little bit earlier. The narratives for the lawyers, flow charts for billing. But I'm going to add on to that and say it's really important for like QA and QI as well. Again, make sure it jives. If you put in your narrative that the patient was administered 4 milligrams of Zofran, but you didn't put it in your flow chart, not only can we not bill for it, we also can't use that for data. Flow chart is where we get our data. Your time estimations. So the big ones I see are application of C-collars and epi administration. We see where like a C-collar is applied like a minute before you get to the hospital on MVAs, for example. That would raise questions as to why it wasn't applied early if you were concerned about cervical spine. Epi administration is my favorite. The ACLS protocol is every 3 to 5 minutes. And you'll like read reports and there's like 8-minute time lapse, or this one was given 1.5 minutes later, or this one was given 2 minutes later. That's not the ALS protocol. So again, that's just something that they pull up and be like, why did you do this? That's incorrect. That's not the standard. Airway confirmation. There is at least an ESO. I can't say the same for others. There is a tab that you can click that says ETI verification. And so anytime you move the patient, you can literally put a flow chart in there that says that you reassess the airway and make sure that it was good. So anytime you move them out of the ambulance, from the cot to the hospital bed, or from the bed to the cot, you can put ETI verification that you can verify the tube was good after you moved them. STEMI, strokes, trauma alerts, there's a tab in there where you can timestamp when you called those. I like to do that, especially on like legit STEMIs and strokes, just to know that I called the hospital at this time and I called the alert. Obviously you guys have that documentation in the hospital as well. Make sure you document who performs the intervention. A lot of people get in the habit of, if it's their run, they put that they did everything. So sometimes you find that patients have gotten a 12 lead and an IV by the same person at the exact same time. I like to think I'm pretty good, but I'm not that good. So make sure if your partner's doing the 12 lead that you document that they've performed that EKG. And again, billing QA/QI grants. We cannot pull data without flowchart. So, and the hospital can probably tell you this better than anybody. When we get grants that come down from the Department of Health, and they're like, how much Narcan usage have you had in your area in the last 6 months? If you're not putting this stuff on the EMS side in your flow chart, we will never get that data, ever. So you have to do the flow chart. Assessments, again, make sure it jives with your narrative. The biggest thing lawyers look at is inconsistencies. So if you've documented in your narrative that the patient has an amputation of the right leg, but in your assessment, you put no abnormalities in the extremities, I would be concerned. Don't click buttons. It's okay that something isn't assessed. People get in the habit of putting no abnormalities, no abnormalities, no abnormalities. On my 16-year-old female with suicidal ideations, I'm not concerned that their genitourinary system is fine. I don't think that needs to be assessed. This is your section to shine. Expand on your findings. At least every EPCR that I've seen, in your assessment tabs, you can also have a little narrative section where you can kind of expand on your thoughts. So sometimes if it says abnormalities other, that's your time to document in there what you actually mean by that.
Or you can draw on most of them.
Or draw. I'm not a very good drawer. And then you move on to the narrative, which everybody's super scared of. But there's several different types. There's a SOAP one where it's subjective findings, objective findings, your assessment plan. START, which is complaint, history, assessment, treatment, and transport. The one that I like to use is DRAP. This is the one that the National Association of Ambulance Compliance kind of recommends as well. All of these are pretty chronological, but this one's best for billing because you talk about your dispatch, what your dispatch do, how you respond to that call, what you see when you arrive, your assessment, your treatment and transport. And if you look at DRAT and you put it right next to an EMT skill sheet, they line up perfectly. So again, lawyers are going to pull some EMT skill sheet to be like, let's see if you met the standard. And that is our standard. So if you're documenting that way, you're pretty much checking all the boxes. Be cautious with your terminology and abbreviations. If you don't know the terminology, there's this great thing called Google, and you can do a little search and it'll tell you whether you're right or wrong. Abbreviations, not a lot of people know this. There's approved abbreviations in our protocols. If you don't, if you don't use the abbreviations that are in your protocols, you're technically not doing it right. And again, this is just little stuff that lawyers look at. So when you put FSBS, for example, finger stick blood sugar. Make sure that that's an approved abbreviation in your protocol. So I'll do you an example of like my narrative. I'm not saying that it's right, wrong, or indifferent, but I'm telling you, billing people want to kiss me on the mouth. QA/QI people want to kiss me on the mouth. I'm sure all the STEMI stroke coordinators would love to kiss me on the mouth because it's usually pretty, every question you have is going to be answered.
My social life.
So this is just a sample call. Medic 7 dispatched to the listed address for chest pain. Medic 7 responded with lights and sirens from station. Medicaid and Medicare love that because that's a billing code. So it was an ALS emergency, or it was an emergency response, changes the billing code. So I arrived on scene to find a male patient seated on the couch clutching his chest. I like to document where I find my patients. There was a crew out of Florida that was under litigation several years after the call because they had allegedly walked in on a patient in the shower and they had no documentation on where they found the patient in their report. Whether that's a common occurrence, I have no idea, but I don't want to be the one to find out. The patient advised that approximately 1 hour prior to our arrival, he experienced a sudden onset of substernal chest pain while sitting on the couch. Patient reports the pain as feeling like a pressure that radiates into his left arm. Patient denies shortness of breathing. Shortness of breath, nausea, or vomiting. So I've outlined some of my pertinent negatives. It's very clear what my patient's complaint is. So I've got my EMT skill sheet. I have my my scene evaluation, my patient chief complaint, and then I move directly onto my primary assessment: airway, breathing, circulation. Patient presents alert and oriented to person, place, time, and event. Airway is open. Patient's able to speak. Noted to be breathing with adequate rate and depth with equal chest rise and fall. And the patient is pale, cool, diaphragmatic with a palpable radial pulse. That's airway, breathing, circulation. I move on to secondary assessment. This could be as significant or as minimal as it needs to be. But a lot of this stuff you can get from just looking at your patient. Normal cephalic, so they don't have any obvious head trauma or changes to their head. Pupils equal and reactive, trachea midline, no JVD, lung sounds clear and equal bilaterally, abdomen soft, non-tender, extremities unremarkable. I like to capitalize on this with, if it's a right arm injury, I'll say pulse, motor function, and sensory present normal in that extremity, or whatever kind of assessment you want to add to that. But that's your time to shine. Then I move on to treatment. So able to stand and pivot from the couch to the cot with assistance ×1. Again, another CMS requirement. How did they move to the cot? Secured to the cot via straps and rails, so that if I get in an accident, I can prove that they were secured. Vitals obtained, put on the monitor, blah, 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 blah. Given aspirin, blah, blah, blah. Transported lights and siren to hospital due to patient request. CMS wants to know why the patient was taken to that facility. Most of the time, if it's the closest facility, it's not an issue. But if you pick up somebody from Tarrytown that wants to go to regional, we need to document why we're bypassing one hospital to go to another.
So why did the patient request lights and?
That's what I was getting ready to.
Yeah.
Listen. It's 7 a.m.
Where's your estimated weight?
So, insurances, for example, especially Medicaid, Medicare, they only pay for the ambulance mileage to the closest facility. So mileage from Union Hospital, regional hospitals on the patient, unless you give thorough documentation as to why they're going to that facility or why it was medically necessary for them to go to that facility. Then I move on to my ongoing assessment. Most of the time, they stay in the same condition throughout entire transport with no new complaints. Patient as well as vitals are reassessed. And then I move on to my arrival at the hospital. So they're moved to trauma 1 via cot. Again, we have to document how they're moved from the cot to the bed. So in this case, it was a sheet lift. Secured in lowest. This is something I do that I don't think a lot of people do. The bed is secured in lowest lock position with rails raised. Unless you don't raise the rails and don't put that. That way, if they roll out of bed, I can show that I put them in a secure bed. If they're put, in a wheelchair in triage, making sure that you're documenting they're put in a wheelchair in triage. And that I give report to the RN who voiced understanding. Acceptance of treatment and transport signatures obtained, blah, 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 blah. So that brings us to signatures. Again, this is probably where most of the billing issues happen, getting appropriate signatures. So there's obviously three different types of, or three different sections of signatures for accepting financial responsibility or treatment and transport. Section 1 is always going to be your patient or the patient's legal guardian if they're a minor. Section 2, healthcare power of attorney, a relative that provides care or a representative of care of an agency that provides care. I'll add a caveat that this is almost never an emergency room nurse. They try to keep it outside of the current billing cycle that's happening right now, I guess you could say, or this current scenario. So this would be like home health care, hospice, whoever. And if none of those people are available, then you get your section 3, which would be your ER nurse and an EMS provider will both sign. You have to have documentation and valid reasoning as to why you couldn't get a patient signature. Weakness is not a valid reason. Blind is not a valid reason. COVID protocols, for whatever reason, made it a valid reason, but it's really not. Even things like patient requests somebody else to sign, that's not a valid reason. CMS will not pay that claim. If at all costs, a section 1 should be obtained by patients. Even if they put an X, there's always a witness directly under it. You can get a nurse to sign as a witness, but you have to get section 1 signatures. I also add receiving signatures. I always get an ER nurse to sign that they received the patient from me, that they received report from me. That I think becomes especially important now that we're taking patients to triage. Just so if they go to triage, they run out the door because they don't want to wait in the lobby and get hit by a truck. I'm like, well, I gave report, they ran away. I don't know what to tell you.
No jinx there, thanks.
Yeah.
I know this is the case in ESO, can't say the same for other EPCRs, but there is a section in ESO for airway confirmation. So if I bring patients to the emergency department with an advanced airway, I have a respiratory therapist or a nurse or a physician sign that the airway was good when they arrived at the hospital. So if there was ever a point that the tube came dislodged, I can prove, hey, it was good when I got here. And then witness signatures. I like to get witness signatures for poorly written section 1s and every single SOR. With witnesses, make sure they're like patient's family members. It shouldn't be another crew member or a guy on the engine. Try and get family to witness.
Law enforcement's okay if they're on scene though, right? Law enforcement is a good.
Oh yeah, for sure. So yeah, that's good. Anybody have any questions on that? Everybody loves documentation.
I will say we still see not probably definitely not your partner, but we still see a lot of responded code 3. It's like,
Oh yeah,
I have no idea what
Plain
that
language.
means. Yeah.
yeah, plain language. That's the approved abbreviation things. People don't even realize that's a thing in our protocols.
Or sometimes you look at it and go, I don't know what they're talking about.
Pretty sure. Yep.
Barry, so
Yes.
how does it get from them doing all of that into the chart? Sometimes we're not seeing it.
This stuff?
Transport.
The transport records are, once they send them, when they hit submit, they automatically go to the state and they automatically go to the facility where they drop patients on.
So ours always shows up under clinical notes.
Yeah, it's on
Yeah,
clinical
it's
notes
on
on your
the
transport record.
Yeah.
Under administrative.
And then if you get to me, I get.
So sometimes there's a glitch because it's technology, because they just, it's a data dump. And so sometimes there's a technology problem. If it's a weekend, you gotta give them till Monday afternoon. And then
I
there's
do, I
one
go
that
up to-
still scans or actually faxes.
But there's several that actually, I think, Star, right?
Star, I think, actually
Yeah.
faxes, yeah.
Store, I think
So, hey guys, up here on the board, there's a QR code for the little quiz or whatever. I didn't actually do a quiz this time, just your name, your service, your PSID number, those kind of things. Again, that'll get you credit for being here. If you sign this sheet, you guys are fine. But if you're online, QR code or you can use the link to do this. And I wanted to, I think that is it for everything for today. Does anybody have any questions or anything you'd like to bring up? New business, Brian?
You have a in-service on Thursday evening down at Regional. We're gonna do it in the education room because y'all HR folks are taking up my room.
This Thursday?
Yeah, this Thursday. It's Dr. Jesse Maskowitz, our trauma director, doing I think what's gonna be a really good in-service on burns.
Okay.
So if they're coming in person, we're gonna do it in the education room up on the second floor professional building.
Okay.
Other than we will have a WebEx for it. And if
Okay.
you need that WebEx, let me know.
All right, anybody else? Thanks, guys. I appreciate everything.
I think I'm holding for that now.
So when are you gonna teach the?
300
What are you thinking?
Documentation.